Hi, everybody. It's Leonard here from irishdermtutor.com. And so for this part of the website, I'm going to talk about psoriasis, which is obviously one of the commonest conditions we see in the dermatology clinic. And so, as with every section of this website, you can, if you want to skip straight to a topic. So, for instance, if I want to skip straight to erythrodermic psoriasis, I can just click on that area here. That jumps down to erythrodermic psoriasis. And then if I want to go back to the top, I can just click back in the top left corner. So for this part of the website, we're going to do an introduction first. I'm going to talk a bit about epidemiology, causes and exacerbating factors of psoriasis, as well as a brief introduction to pathogenesis. And then move on to the various subtypes of psoriasis. We'll move on to psoriasis associations, such as nail psoriasis and psoriatic arthritis, and talk a bit about doing a severity assessment in psoriasis. We will then move on to treatments, starting with topical treatments, phototherapy, and conventional systemic treatments, such as methotrexate and cyclosporin. And then we'll move on to the biologic agents. At the start of this section, we'll just go into a bit more detail about pathogenesis, and then we'll go through the various biologics that can be used. So we'll go ahead and get started. So, psoriasis, as I said, is extremely common, and it's a chronic inflammatory skin condition and one of the commonest conditions we see in dermatology. It tends to affect about 2 to 3% of the population in Europe, and it affects men and women equally. But men are more likely to have severe disease, and it tends to persist lifelong, but it fluctuates in extent and severity. And about 1/3 of patients with psoriasis will have a family member with psoriasis. The age of onset tends to be bimodal. So there can be an early onset that can occur in people under the age of 30. And this accounts for about 75% of cases. And there tends to be a HLA CW6 association. And I'll talk a bit more about that in a small bit. These patients are more likely to have a family history, and they're more likely to have a severe unstable disease. Then there's a later onset, which often occurs in people over the age of 40, and this tends to be sporadic and is not HLA associated. So what causes psoriasis? So like many autoimmune conditions, the genetic, environmental factors, and the immune system all play a role. From a genetic point of view, studies have reported a 72% concordance in monozygotic twins and 23% in dizygotic twins. And more recently, genome-wide association analysis has mapped at least 80 loci that can be associated with psoriasis. The major psoriasis susceptibility locus is termed SORS1, and it lies within the major histocompatibility complex on chromosome 6. And within this locus, HLA C602 is the genetic variant that makes the largest contribution to psoriasis susceptibility. So essentially, if you inherit one allele of HLA C602, this increases a patient's chance of getting psoriasis by 4 to 5 times. So we all know that environmental factors can play a role in psoriasis and can play a role in exacerbations of psoriasis. So, for instance, infection can sometimes trigger it. So streptococcal infection can cause a flare of psoriasis, particularly the gut agent subtype, which we'll discuss later. And interestingly, if you were to take a sample from the tonsils, you'd find a T cell repertoire that is quite similar to that is found in the skin in psoriasis. Medications can play a role. I suppose one very important one to be aware of is steroids can often flare psoriasis. So oftentimes, if a patient with psoriasis is treated with steroids for whatever reason, it may be for the psoriasis or for something else, when they stop the oral steroids, they may notice that they develop a bad flare of psoriasis, or sometimes they can even develop a flare of pustular psoriasis. And other medications that can be implicated include lithium, beta blockers, antimalarials, and interferon alpha. And then a very interesting kind of paradoxical effect that can sometimes occur is that patients on TNF alpha inhibitors, so they might be on these for reasons other than psoriasis, such as inflammatory bowel disease. And sometimes these patients can develop a paradoxical flare on the palmoplantar areas and the scalp. And this tends to be a class effect. So if they get this with one TNF alpha inhibitor, they are likely to get it with another. So smoking can be associated with psoriasis. So the rate of smoking is increased in psoriasis patients compared to the normal population. And in particular, palmoplantar pustulosis is almost exclusively seen in smokers. And it's still unclear if smoking cessation actually helps improve the condition once it has developed. And like many dermatology conditions, stress is often reported to flare psoriasis. And in some studies, up to 80% of patients report worsening of psoriasis in relation to psychological stress. Endocrine factors can play a role. So, the pregnancy, thankfully, actually, psoriasis often improves during pregnancy, but it can cause a flare as well. And then hypocalcemia can sometimes cause a flare of psoriasis. And trauma can play a role in psoriasis. So there's a thing called covernalization. And this is the appearance of skin lesions of a pre-existing dermatosis on areas of cutaneous injury. So, if patients are scratching a lot or if they get trauma to an area, you might see psoriasis in those areas. And question that often comes up in exams is maybe other causes Koebner phenomenon. So things that can also do this include lichen planus, vitiligo, molluscum contagiosum, and bullous pemphigoid. So we'll now move on to what role the immune system plays in psoriasis. And I will go into this in more detail later when I'm discussing the biologics. So if you're interested in that, you can skip to that section. But essentially, psoriasis is a T cell mediated disorder primarily driven by pathogenic T cells. It involves prominent involvement of helper T cells and their secreted cytokines. So essentially, you can get increased level of T helper 1 cells and T helper 17 cells. And each subset of these cells secretes what I call their own signature cytokines. So the cytokines you see that are raised in psoriasis include TNF alpha, interleukin 12, interleukin 23, and interleukin 17. And these all contribute to the disease. And as such, these are the targets of the different biological treatments we use. The T cells then can interact in a complex way with dendritic cells, keratinocytes, and neutrophils. And under the influence of various cytokines, this leads to keratinocyte proliferation, neutrophil chemotaxis, and angiogenesis. And this gives us the picture of the psoriatic plaque. Of note, keratinocytes usually move from the basal layer to the upper layer in about 28 days. And in psoriasis, this is much reduced and is about 3 to 5 days. And as I said here, if you want to click here to skip this to discussion about biologics and cytokines pathway, we'll go into more detail there. So I know that was a bit heavy going, but we'll now move on to more clinical aspects of psoriasis. So the commonest subtype we see is chronic plaque psoriasis. And in this, you get symmetric distribution of well-demarcated plaques. And so as we can see here in this patient, you get these well-demarcated salmon pink, as it's often referred to, plaques, and you often see a silvery scale. Here is another image of the classic plaques we see in psoriasis. And so it often occurs in common sites. So, I'd often look at these areas always if I'm suspecting psoriasis. So I often see it in the scalp, the extensors of the elbows and knees, the sacral area, and often on the hands and feet. And other areas that I might look for that might be a clue to psoriasis, if I'm unsure, is that it might occur behind the ears, the nape of the neck, and the umbilicus. And as we know, it can range from very mild, where you might just get a few plaques, for instance, on the elbows, to very extensive, covering much of the body surface area. And here's an image of scalp psoriasis, and this can really have a huge impact on the patient's quality of life. It can be very severe, where you get this very thick scale covering the whole surface of the scalp, and that can often shed a lot. So the patients can often be very embarrassed and can be very itchy as well. And flexural psoriasis can often occur, and it looks a bit different from psoriasis in the other areas. So kind of the moist occlusive surface means that you can't build up the scale. So you often don't see the classic scale of psoriasis, but it often might have a kind of salmon pink or kind of reddish color. And it might also be complicated by, due to the area, you might often get these little satellite lesions which are superimposed over growth of candida. So oftentimes for these areas, you might use a combination topical cream. So you might, for a very short period of time, use a strong steroid antifungal combination like Lotriderm, or you might use a moderate steroid antifungal combination such as Trimivate. So Trimivate's available in the UK. I'm actually not sure if it's available in Ireland. And then genital psoriasis can often occur as well. And it's very important to ask patients about this because they probably won't be very forthcoming with it. And it can, cause a big impact to their quality of life, and cause an impact to sexual function. It can be quite difficult to treat as well. We'll now move on to guttate psoriasis, which you often see this in children or young adults. And it's described as these widespread small plaques, as can be seen in this image here. And gutta is Latin for raindrop. And it often occurs following a streptococcal infection. So you can look for an elevated ASO titer, which might point towards this diagnosis if you're unclear if that's what it is. And oftentimes it's self-resolving, usually over a period of months, but sometimes it can be a bit more persistent. And 40% of patients that get guttate psoriasis originally will go on to form a chronic plaque psoriasis. And really, because it's self-resolving, treatment can simply just be symptomatic. So you might give just regular emollients and maybe moderate topical steroid to help with that. And you could give, if it's persistent or if it's very itchy, you could book them in for a narrowband UVB treatment, which can help as well. So we'll move on now to pustular psoriasis. Now, this can be generalized or it can be localized. And if we break up generalized variants, you can get the one probably that's most known is acute generalized, which used to be called pustular psoriasis advanced en bouche. And you can get something called subacute annular and circinate pustular psoriasis. And really this is where it's like plaque psoriasis, but you can get little pustules within the plaques, but usually the patient is generally well. And then you can get acute generalized pustular psoriasis of pregnancy, which is obviously similar to acute generalized pustular psoriasis, but occurring in a pregnant person. And then you can get localized variants of pustular psoriasis. So something called panoplantar pustulosis, which might actually be a distinct entity compared to psoriasis, and something called acrid dermatitis of Palapio, which I'll go into in a bit as well. So when we're talking about acute generalized pustular psoriasis, really there are two main groups overall. And so one is where it arises in patients who already have chronic plaque psoriasis. And then something may have just triggered that to cause a pustular eruption. So certain triggers could include pregnancy, as mentioned already, or sudden withdrawal of steroids, as I've mentioned already. Other medications might do it, like beta blockers, aspirin, and anti-inflammatories. Infection might do it, or hypocalcemia can do it. But you can also get a generalized pustular psoriasis that just arises by itself, and it may be the only manifestation of psoriasis, and they might not have ever had psoriasis before. So recent research actually suggests that generalized pustular psoriasis and panoplantar pustulosis may be distinct from classical psoriasis, and they might have a different pattern of immune activation. So generalized pustular psoriasis alone may be associated with IL-36 receptor antagonist mutations, and generalized pustular psoriasis patients with preceding chronic plaque psoriasis may be associated with CARD14 mutations. And so particularly the first one, the IL-36 receptor antagonist mutations, this might have implications for future therapeutic options for pustular psoriasis. So in regards to the presentation of an acute generalized pustular psoriasis, and this is a dermatology emergency, really, and it's often precipitated by a burning sensation in the area, and they may get dry and tender skin. And then all of a sudden, they might develop these lakes and plaques of pustules. So you might get some individual pustules in the area, or sometimes these individual pustules coalesce and cause these lakes. And the patients might become erythrodermic with pustules studded throughout the body. And I do think I have an image down here. So so this is a particularly severe form of pustular psoriasis. You can see they've got widespread erythematous rash, and then they've got some studded pustules throughout the body, and in areas on the upper neck here, you can see that they've coalesced to form these lakes that I had mentioned. And so with time then, as the pustules dry out, you might get exfoliation of the skin. And nails are often involved in this condition, and as I mentioned, it is a dermatology emergency. Patients can be very unwell with it, and they might have a systemic inflammatory response. So, they might have fevers, they might have very raised inflammatory markers, and they might have signs of skin failure, such as electrolyte abnormalities, dehydration, and tachycardia. So how do you manage it? So, if it is a bad flare and they're unwell, they need to be admitted. And you need to screen for infection because, as I mentioned earlier, infection can cause a trigger of pustular psoriasis. And it can sometimes be very difficult to tell if a patient is septic or if it's simply they're having a systemic response to the pustular psoriasis itself. So it can often be very difficult. So you need to do the full screen. And you probably should give them a regular emollient spray, which is a spray of 50-50, essentially, is a good option. And I won't go into this in detail, but it can be a bit controversial whether to use topical steroids or not. Some think that maybe using a strong topical steroid might exacerbate a flare, whereas some people might use a strong steroid to try to get it under control. And so I won't wade into that right now, but they also will need hydration, they'll need analgesia, and they'll need to have their bloods monitored. And then if infection can be excluded and it's quite severe, you might need to consider systemic immunosuppressive. And cyclosporin tends to be a good one at getting things under control quickly. But there are other options. So now moving on to the less severe, less acute condition of palmoplantar pustulosis. And essentially, this means pustulosis of the palms and soles. Here's an example of quite a well-defined patch of plaque of pustulosis, and you can see that pustules tend to be in varying degrees of evolution, and due to the thickness of the soles of the foot, you can see these varied forms. So sometimes they can look very acute, and they can look yellow or green. And in this case, actually, a lot of the pustules seem to be quite drying out, and they're kind of brownish. And as mentioned previously, it almost exclusively is seen in smokers. And the patients often can report a sensation of it being very uncomfortable, and sometimes they report it feeling like walking on glass. And this disease tends to run a chronic course. And oftentimes, this is the only psoriasis or form of psoriasis they have, and they don't have any psoriasis elsewhere. And then moving on to an even more localized type of psoriasis, which is called acrodermatitis of Halley-Pune. And these patients essentially get these sterile pustules, which may start at the at the tips of the fingers and toes, and then they spread more proximally. And the striking feature with this often is that they can have very dystrophic nails, and oftentimes you may lose the nail. And sometimes the terminal digit may atrophy, and this is called acral osteolysis. And again, this is very difficult to treat, and options include cyclosporin, but of course, this is not a long-term option, and acitretin, and some reports have shown efficacy with apremilast. And then moving on to the final clinical subtype of psoriasis is erythrodermic psoriasis. And erythroderma stands for, depending on the definition, it can be either greater than 80% or greater than 90% body surface involved with a red scaly rash. And when a patient's erythrodermic, they get problems with temperature regulation and fluid loss. So here's an image of a patient with erythrodermic psoriasis. And you could probably tell that this is psoriasis that is the cause of erythroderma, and as you can see the silvery scale that the patient has here. And just to be aware, there are many causes of erythroderma. Psoriasis is a common one. Other common causes include eczema and drug reactions. And then maybe less common causes include things like pityriasis, rubra pilaris, or cutaneous lymphoma, among others. So I hope to somehow get pathology slides in the near future. I won't go into histopathology in great detail, but superficially to deep, if you're looking at a slide, you will see neutrophils in the stratum corneum, and this is important when looking at the pathology slide to help diagnose psoriasis. And you get parakeratosis, you get loss of the granular layer, and then you see something called psoriasiform hyperplasia of the epidermis. You get thinning of the suprapapillary plates, and you get capillary dilatation and edema in the dermal papillae. And the two things you might see when you read about it is you can get neutrophil collections, And if you get a collection of neutrophils within the stratum corneum itself, they're called one-row microabscesses. And if you just get a subcorneal collection of neutrophils, it's called spongiform pustules of Koch. And so that might all be gibberish to some people reading, seeing this video, but I hope in the near future to go into that with some slides, so it makes more sense. So psoriasis has many associations, and you really need to think of psoriasis as a systemic inflammatory disease. And you need to inquire about other things whenever you're dealing with psoriasis. So psoriatic arthritis is obviously very common, and nail psoriasis is very common in psoriasis patients. But you also need to consider that patients with psoriasis often have associated metabolic syndrome. So they're more likely to have hypertension, dyslipidemia, insulin-resistant diabetes, obesity, and crucially a higher cardiovascular risk compared to the normal population. Like many dermatology conditions, there's a huge psychosocial aspect associated with psoriasis. So they often can get a reactive depression. And a UK GP database study showed that psoriasis patients are more likely to have a diagnosis of depression with a hazard ratio of 1.39 and a confidence interval of 1.37 to 1.41. So that's quite a narrow confidence interval. And approximately 20% of patients that have psoriasis might be treated with antidepressants in some studies. And there have been some reports of higher rates of suicidal ideation. And alcohol again is associated now is part due to their alcohol or their possibly unhealthy lifestyle that they're getting flares of psoriasis, or is it that there's inflammation from the effects of having psoriasis leads them to drinking alcohol? And it can be unclear, but excess alcohol or alcohol misuse is reported in about a third of patients with moderate to severe psoriasis. And as mentioned, it can be associated with more severe disease, and it's important to screen for when you're seeing psoriasis patients, as it can also impact with your decision to do certain treatments, for instance, methotrexate, which can impact the liver. And then other associations, which I won't go into much detail about, include inflammatory bowel disease and sometimes ocular inflammation. So we'll talk a bit more now about nail psoriasis. So nail psoriasis is present in approximately 45% of patients with psoriasis. And an important clue to psoriatic arthritis is that 80% of patients with psoriatic arthritis have nail psoriasis. So if they're complaining of joint pains, it's always a good thing to look at the nails for these signs. And so unfortunately, this probably isn't a great image of the kind of classic signs seen in psoriasis, but what you often see is you can see these little, again, it's not great, but you can see little pits in the nail plate, which can be studied throughout the nail plate. You often see onycholysis, which is separation of the distal nail plate from the nail bed. So it often looks a bit whiter in the distal area and looks raised off the nail bed. And you can sometimes get what's called little oil spots on the nail plate, which essentially look like little oil spots. And then sometimes, probably in this case, you can the whole nail can just be quite dystrophic. And essentially, it depends where the psoriasis is in the nail, what you get. So if the nail matrix is affected, and if it's very kind of focal, the nail matrix affected, you get these little pitting areas because it's very focal. And if it's a lot of the nail matrix affected, you'll get ridging and nail dystrophy. And then if it's just the nail bed that is affected, so a bit of psoriasis in the nail bed under the nail plate, you'll get the nail lifted off the bed. So in those cases, you get onycholysis, oil drops, and subungual hyperkeratosis. You may often see splinter hemorrhages in psoriasis as well. And unfortunately, nail psoriasis is very difficult to treat. So the topical preparations we use don't really penetrate the nail bed or nail matrix. So it can be quite frustrating to treat it. So we'll move on now to psoriatic arthritis. So 15 to 30% of patients with cutaneous psoriasis will get psoriatic arthritis. And it can occur prior to skin involvement, but usually it occurs after skin involvement. There are different ways that the psoriatic arthritis can present, and one mnemonic I sometimes think of is drama. and that's the various ways it may present. So sometimes patients just get DIP, joint predominant disease, and this is a very specific way that inflammatory arthritis presents. There are no other inflammatory arthritises that I'm aware of that cause DIP, joint involvement. And sometimes you can get a rheumatoid arthritis-like presentation. So we often get a symmetric arthritis of the small joints of the hands, and that can mimic a rheumatoid arthritis type presentation. You can get an asymmetric oligoarthritis that may affect the larger joints. You can get a thing called arthritis mutilans, and this is where the hands or feet are really grossly deformed. You get kind of reabsorption of the bone, and sometimes they're called opera glass hands. And thankfully, this is rare nowadays because the treatment and identification of psoriatic arthritis has improved. And finally, you can get an ankylosing spondylitis-like arthritis, where they can get lower back pain and stiffness in that area. Now, I have got into more detail at the very end of my notes here on psoriatic arthritis. So if you're interested in it, you can click on this link. So obviously, when you're dealing with a patient that has psoriasis, it's very important to do a severity assessment, both on the objective, how much of the skin is involved, but also how much is affecting the patient. And this really can guide what treatments are appropriate. And sometimes you need a certain amount of severity to give a certain treatment. So different severity scores can be used to measure how clinically severe the psoriasis is, how it affects the patient's quality of life, and to screen for psoriatic arthritis. And so the common one we use to objectively measure the extent of psoriasis is the PASI score. And it's based on the body surface area affected and the degree of erythema, induration, and scaling that is affected in different parts of the body. And so oftentimes, if you're in a dermatology clinic, you might, if you see a psoriasis patient, you might actually be given the sheet with a PASI score to fill out yourself, or else you can actually download the PASI calculator app on your phone. Or what I often do is I just click on the link here, which takes you to a site. So let me see if I can do that now. Oh, sorry. So this is the link I clicked to, and then you can really fill out all the various things, and it gives you a score. So that that's a very good objective score, and we'll talk about how that impacts treatment advice later. And then there's something called a DLQI, and this is a questionnaire that is used for a variety of skin diseases. It's not specific for psoriasis, and it measures the impact that skin disease has on the patient's quality of life. It's scored out of 30, and it asks how the skin disease has impacted the patient over the last 7 days. And again, a simple Google or whatever search engine you use will bring this questionnaire up. Although, again, it's quite easy to find in the dermatology clinic. And finally, there's something called a PET score, and this is a screening tool for psoriatic arthritis. And patients with psoriasis who do not have a diagnosis of psoriatic arthritis should ideally complete an annual PET score. And a score of 3 or more indicates consideration for a rheumatology referral. And so on the score, you'll actually see an image of a person's body with all their joints with a square around it, and they're asked to tick all the joints that are affected on the image. And then it asks the following questions. Have you ever had a swollen joint or joints? Has a doctor ever told you you have arthritis? Do you have fingernails or toenails that have holes or pits? Have you ever had pain in your heel? Or do you have a finger that was completely swollen and painful for no apparent reason? And so, as I mentioned, a score of 3 or more indicates consideration of rheumatology referral. So I'll take a little break from talking about psoriasis, and we'll move on to treatments very soon.